Well, good morning, ladies and gentlemen. I'm very pleased to welcome you to this morning's session on the patient's perspective on hypoparathyroidism. This is a patient's voice session, and we will have two expert speakers talking on hypoparathyroidism. We'll have a moderated discussion, and then I'll be happy to take question and answers. Of course, hypoparathyroidism is the last endocrine disease where the replacement therapy has not been available in until recently, when we've now been able to move towards injectable therapy with PTH, and work is going on apace on long-term active substitutes for PTH and oral preparations of PTH. But at the moment, we've not got the full spectrum of replacement therapy, and so we would like to discuss today the patient's perspective and where we are with treatment and what can and cannot be done. And first of all, I'll hand over therefore to Professor Jeremy Turner, who's my colleague at Norfolk and Norwich Hospital, professor in endocrinology. He'll discuss the patient's perspective from a clinical expert's point of view, and then over to Liz Glenister, who's from Parathyroid UK, and she'll talk about the impact of the condition on patients and the work of Parathyroid UK. So very pleased to welcome you to this session. So to say, I'm Bill Fraser. I'm Dean of the Medical Faculty at the Medical School at Norwich and Professor of Medicine. My qualifications are in metabolic medicine, and I work with Professor Jeremy Turner at Norwich. So without further ado, we'll move on to the presentations. And the first presentation's from Professor Jeremy Turner. He's going to give an idea on the patient's perspective on hypoparathyroidism.
Hello, my name is Jeremy Turner. I'm a consultant endocrinologist in the Norfolk and Norwich University Hospital in Norfolk in the east of England. I'm a medical advisor to Parathyroid UK. My thanks to the organisers of this meeting for asking me to give a brief introduction on hypoparathyroidism for our session on the patient perspective on hypoparathyroidism. Hypoparathyroidism is often described as an orphan disease. This is a disease that can be defined as one with a prevalence of less than approximately 1 in 3,500 people in the population, or alternatively, one that, quotes, has not been adopted by the pharmaceutical industry as it provides little incentive to make and market new medications, close quotes. This definition is no longer strictly applicable, as many of you will be aware. Until very recently, hypoparathyroidism was the only endocrine deficiency state not treated by hormone replacement therapy. But we do now have the availability of recombinant human parathyroid hormone, 1 to 84, or full length. More on that later. However, for the foreseeable future, the majority of patients with this condition will still continue to be treated with activated vitamin D metabolites and calcium. So a little bit on the management of chronic hypopara. We are in the fortunate position of having several authoritative consensus guidelines now on the management of this condition, and I've summarised perhaps 3 of the most widely recognised ones on the left-hand side of this slide. We've got the European Society for Endocrinology Clinical Guidelines, Boleslev et al. From 2015. We've got the Brandy et al. Guidelines from 2016, and then more recently we have the Khan et al. Canadian and international guidelines. They tend to say broadly similar things, and I've taken the bullet-pointed list on the right of this slide from one of these guidelines, and they tend to say things like maintain serum calcium level in the lower part or slightly below the lower limit of the reference range. Keep an eye on the 24-hour urinary calcium excretion, try to keep that within the reference range. Serum phosphate levels should be within the reference range in order to avoid a high calcium phosphate product and risk of ectopic calcification, etc. So on the surface of it, following these guidelines should be relatively straightforward, and the majority of patients with this condition, in theory at least, should be able to receive high quality care for their hypoparathyroidism. So how are we doing? Well, in 2017, the charity Parathyroid UK commissioned a report on living with chronic hypopara. And this was a survey of approximately 230 of their members with this condition. And the sad truth of the matter is we are doing shockingly badly. Some of the headlines results are summarised in this slide. And as you will see, only 11% of patients with this condition were under the care of a specialist with particular expertise in this condition. 2/3 of patients felt that their care could be improved upon. 71% of patients found that their condition was having a significant impact on their ability to maintain their normal lifestyle, and 22% of patients, so more than 1 in 5, were having an unplanned hospital attendance or hospital admission every year. Some of the morbid burden in terms of symptomatology is summarised in this right-hand column here. 70% suffering from bone pain, 51% migraine-like headaches, 67% depression, 61% dizziness. So there is clearly a really significant symptomatic burden associated with the condition. This report is not alone. This slide here highlights the results from the Paradox study, a large US online survey of over 370 adults with this condition, and it shows similar findings, and I've highlighted the key findings in yellow here. And shockingly here, 80% of respondents to this survey had had an unplanned hospital stay or an emergency department visit. So clearly we need to do better. How are we going to do better? This is the question. In the UK, in the NHS setting, we now have the GIRFT, or Getting It Right First Time initiative, which is in essence a quality control process where specialists from each specialism make departmental visits and submit reports on what they think can be done to improve the service, and also to attempt to standardise the quality of service that each department is giving. And we also now have the SSQD, or Specialised Services Quality Dashboard, which again is another centrally administered quality control initiative. And within this, I'm pleased to say that there are now 2 questions specifically on the management of chronic hypoparathyroidism. So there are forces at play in the background to improve services. My own opinion, how can we make things better for patients with chronic hypopara? I've summarised my 4 key bullet points here. Please communicate with your patients. Please listen to what your patients are saying. Please remember that it's not all about the numbers and the blood tests. Please hear what they are reporting about their symptoms and prioritise symptom control as well. Please make frequent blood tests easily available with open access to both the testing and the results. This will help. And finally, what of the future? Well, I'm pleased to say that we are now entering the dawn of a new era with recombinant human parathyroid hormone, rhPTH124, starting to become available. And there is a nice evidence base showing that one of the things that this really improves is quality of life for patients. So I'm cautiously optimistic that things will get better. Thank you.
To the patient's perspective from Liz Glenister, who is from Parathyroid UK, the CEO and founder of this organisation, the large number of patients who are party to this organisation, and she will now give a talk on the patient's aspect of hypoparathyroidism.
Hello everyone, thanks for tuning in. Thank you very much to Bill and Jeremy for kindly joining me today, and to the ESE for creating this brilliant opportunity for patients and clinicians to come together online. I'm going to tell you a bit about what we do, how Hypopara impacts patients, and then Jeremy and I will talk about some of the challenges facing patients and clinicians and how you can help. I've got post-surgical hypoparathyroidism following a thyroidectomy for thyroid cancer 28 years ago, when primary hypoparathyroidism was well known, but hypoparathyroidism was still largely unrecognised and no information was available at all. So I set up Parathyroid UK in 2005, and today we have nearly 3,500 members, of whom around 70 to 75% have permanent hypoparathyroidism of various types, and 75% of those have post-surgical hypopara. We're supported by and work closely with these fantastic specialists, some of whom you may recognise. Thanks to their dedication and our own awareness raising efforts and the rise of interest in rare disease over the past few years, Hypopara is thankfully more widely known, but we still have a long way to go. Hypopara remains a challenging condition to live with and is difficult to manage. Demand from patients for reliable support and information is very high, and we run 4 very busy online support groups for UK, European and worldwide patients. Our website is packed with reliable information, and our advisors help us to develop patient information leaflet, which you can order online from our website or from our stand here at the ECE. And because of the unplanned hospital visits patients have to make and the problems they meet while they're there, we've had to develop and produce a medical emergency card. And we hope there'll soon be a Europe-wide standardised card as well. We spend a lot of time raising awareness about the condition to the medical profession, and we've also helped to set up new patient groups around the world, including Hypopara Europe Network and a World Awareness Day. Patients with a lifelong condition become family, and last year Hypopara patients from 27 countries attended our Awareness Day meeting, so we not only have a louder voice now, but a large and willing database for research possibilities. In terms of research, enormous strides have been made so that in a relatively short space of time we now have clinical guidelines, new treatments and a home blood tester in the pipeline, and hopefully soon better tools to prevent post-surgical hypopara. We've been involved in much research, and most recently the Burden of Life study from 13 countries, which found that patients with not adequately controlled hypoparathyroidism reported substantial symptoms and impacts on their quality of life. Despite all this, managing hypoparathyroidism remains a challenge. Surgery may have had traumatic results. Diagnosis of genetic conditions may have taken sometimes years or been misdiagnosed. Like diabetics, our levels can also crash, but unlike them, we have no home test or a replacement hormone to help us manage. On top of that, the condition is rare, still quite poorly understood, and standards of care vary widely. So for the patient, this can all have devastating impact on their lives and the lives of their families, and they frequently find themselves not just on a quest for understanding, but on a roller coaster of symptoms. Not only are these symptoms horrible, but the daily management of calcium levels without a feedback mechanism is a constant and frightening juggling act. Trying to also maintain the serum calcium level high enough to prevent symptoms but low enough to protect renal health is a Sisyphean task. At the back of every patient's mind is the memory of their worst hypo and the fear that it might happen again. Symptoms can very often trigger that fear as well. They tend to develop along the spectrum, if untreated, from mild to severe, and affect the patient not just physically but neurologically as well. Mental health issues can be quite significant. Onset may be quite sudden, and this unpredictability makes it hard to plan or hold down a job. you become unreliable and feel unsafe in your own body. This, along with not being properly understood or correctly treated, creates a lot of extra anxiety in a condition where low calcium already does this for you. So, in our survey of 530 patients last autumn, 85% were very worried, not of COVID, but of becoming ill with hypopara, having to be hospitalised, and their condition not being properly recognised or managed. The fear is real. So what can be done? We need three things. We need good management. Our groups are full every day with patients unable to get the help they need and who want to learn how to balance their levels and get their lives back. We follow a low or no calcium protocol that's been tried and tested and has shown good results, and it's even got some data to back it up. Secondly, we need new treatments, and we urgently need a home tester. And finally, we need you. We don't want to do this all by ourselves, but we often feel like we have to. So we ask you to please listen to your patient, read and heed the guidelines, visit our website, educate yourself about our rare condition, and come along to our stand here at the ECE. So next I'll be talking to Professor Turner about some of these management issues with a Q&A at the end. And here's one for you. Can you tell if my calcium was high or low when we made the next recording? Thanks for watching.
Thank you very much, Liz. So we'll now go into a discussion session between Liz and Jeremy, and then we'll move forward. I can see we've already got some questions in the question and answer sessions. I will review those, and I will put those to Liz and Jeremy after the discussion. So let's move on to some discussion between our two speakers. Thank you.
So I think we were expecting there to be a recorded discussion.
There's a recorded discussion that should be happening now, please. There we go. Moderated discussion. There we are. I think we're in now. Thank you.
I'd like to ask you about living with chronic hypoparathyroidism is you'll have seen from the slides that I've just presented that an alarming number of individuals with this condition end up having unplanned attendances at the emergency department of their local hospital every year. Can you tell me a little bit more about your own experience of this, please?
Yes. Sadly, we find this is a really frequent occurrence when people have been told to increase or decrease their medication by too much or too fast. We find that any adjustment needs to be made in the smallest possible increments and very gradually over time, because even the smallest adjustments can cause quite dramatic symptoms of hypo or hypercalcemia for the patient.
Yeah, I would absolutely agree with that. I think that amongst specialists who practice right in this precise area of medicine, frequently or a lot of their professional time, I think there's awareness of quite how powerful a change as small as just 1/4 of a microgram a day of alpha-calcidol or calcitriol can be. But I think outside of our immediate specialist, subspecialist field, I don't feel that that awareness is so good. And I absolutely agree with you. You see some significant increases and decreases being made, perhaps without full understanding of quite how potent activated vitamin D metabolites are. And of course, the analogy in my mind is that it's a little bit like driving a car, but only with an accelerator pedal, without a brake pedal. So you can press on the gas or you can lift off the gas, but after that, you just have to wait for the car's speed to change, don't you? You haven't got the other mechanism of slowing things down or speeding things up.
Mm-hmm.
You will have noticed also that in a lot of the guideline documents, there's quite a lot of evidence given to biochemical parameters for managing patients with chronic hypoparathyroidism, specified ranges of albumin-adjusted calcium levels, specified ranges for target ranges for 24-hour urinary calcium excretion, etc. Do you really think that that's the whole picture from your perspective, or do you think we should be taking other factors into consideration as well?
Well, I think the main problem is the idea of the normal calcium range for patients. So often we're told that our test results are normal, and so everything is fine, when in fact we're feeling very unwell and not fine at all. The normal calcium range is very wide, and hypopara patients can feel really quite unwell at either end of that range, and most people tend to have a quite narrow window within which they feel comfortable and symptom-free, and try to maintain calcium at that level.
Yes, it's a shame that very often we haven't got a preoperative level, accepting that thyroidectomy or other anterior neck surgery is often the cause of hypoparathyroidism. It's a shame that we often don't have a preoperative reference level so that we perhaps have a better idea of what the target range for an individual patient should be. I think that sometimes, as a clinician who practices in this area a lot, you can infer what the patient's likely preoperative calcium level was, or what their normal calcium level should be, because eventually you will find a sweet spot where they are less symptomatic than at other levels, but it can take a long time to find that. And of course, as a clinician, it's particularly disconcerting when that target level is outside of the 2 to 2.3 millimole per litre adjusted calcium level, which is often advised in many of the consensus guideline documents, especially if it's higher than that. As a clinician, I find myself worrying that I'm exposing the patient to increased risk of future nephrolithiasis, nephrocalcinosis.
Yes, it's tricky, but I think that also has to be balanced with quality of life as well. And for some people, it's actually really quite difficult to maintain their levels so low, because it means they're constantly struggling.
Absolutely. So we've got this terrible tension between potential benefit of risk mitigation in the future versus the potential side effect cost of reduced quality of life in the here and now.
Yeah.
And I think most of us, if we imagine ourselves in the patient's shoes, we know where we would like to be, and I'm presuming that you would reiterate that. Okay. Tell me about in your opinion, about the balance between the emphasis that different clinicians put on the amount of calcium carbonate or other oral calcium supplementation and the role of activated vitamin D in your treatment. Do you think we get that balance right?
No, not on the whole. We have so many people who come to us who've been prescribed with really large amounts of calcium, and very little active vitamin D, so that they're struggling to maintain stability and feel dreadful. Calcium is really short-lived and simply can't support our levels without constant swings going on. Plus, it's very astringent. So reversing this, increasing the alpha-calcidol slightly, reducing the calcium, makes an enormous difference.
Yes, and of course the fundamental physiology here is that you need activated vitamin D, so 1,25 dihydroxyvitamin D, to drive, or at the very least to facilitate, enteric absorption of calcium. So in actual fact, if one stops and stands back and looks at the broader physiological picture here, you can see that overemphasizing the oral calcium supplementation and underemphasizing the activated vitamin D metabolites is likely to be the wrong way to go the majority of the time. I suspect that many colleagues, many clinicians have been given a healthy respect for activated vitamin D metabolites because they are most assuredly not without their risks. And we've all seen significant cases of iatrogenic hypercalcemia over the years. And that healthy respect sort of translates into a therapeutic caution. Yes. And I suspect that's where some of this comes from.
Yes. Also, I think I'm not sure, but correct me if I'm wrong, that 1 microgram seems to be the sort of cut-off point for the normal population. But in hypopara patients, our average dose in amongst our members is 2 to 3 micrograms, with actually a small handful of people even on 6 to 7 micrograms.
Absolutely, and that I think is a particularly important point. The individual variability in dose requirement from one person to the next for activated vitamin D metabolites. And again, getting back to my earlier point about caution around activated vitamin D metabolites, sometimes you have to be quite professionally brave to overcome this caution and say, here is an individual who just seems to need more, and presumably there's complex underlying pharmacogenetics and pharmacokinetic factors involved in this, but it is a simple therapeutic clinical fact that some people need appreciably more, and if they need more, give them more. I suppose the watchword is close monitoring, careful monitoring, and that way will keep everybody safe. I guess that's the important point there.
Yes.
What would be your ideal recipe from your lived experience of having lived with chronic hypoparathyroidism? How much do you want to take activated vitamin D? How much do you want to take calcium supplements? How much do you want to take other things?
Well, the ideal, and we've tried this with several hundred people now, which seems to work and makes us feel more stable and much happier, is to have sufficient levels of alpha-calcidol, vitamin D3 and magnesium. And we tend not to focus so much on the calcium, just using it really for emergencies and top-ups.
Right. So that rather picks up on the previous point, I guess we were discussing about the balance between activated vitamin D and calcium, but you're extending it out to vitamin D, plain vitamin D, which of course is referenced in most of the consensus guidelines, and magnesium as well. And I think that's a really important point, and I don't think that awareness of that amongst the broader health professional community may be as good as it could be, in all honesty.
Yeah, and there's actually surprisingly a lot of confusion about alpha-calcidol and ordinary vitamin D as well.
Yes, and a sort of perception that if you're on activated vitamin D, you don't need the plain stuff. But of course, for connoisseurs of the field, we know there's a little bit more to it than that, we think. Tell me a little bit about the need for self-management. How much of the management do you think should be done by the doctor, or how much of it should be done by the patient? What's the sweet spot on the balance there?
Well, we'd like to be managed by our doctors, but the actual reality is that calcium fluctuates all the time in response to so many different things, and not just medication, but stress, diet, exercise, infection. And it changes over time in response to estrogen levels. So it's not a simple thing to manage. And if you take into account that patients are trying to maintain fluctuating levels as best they can without immediate test results, without knowing whether they're high or low, without being able to access their endocrinologist, or without support from their GP, who won't act usually without say-so from the endocrinologist, and all when feeling very unwell and also very anxious, then self-management is really quite necessary.
Yes. Yes, I absolutely agree with that. But it needs to be collaborative, doesn't it?
To be able to do it.
Yeah. Thank you. Liz, I think it's...
Right, so we've now got a very short period of time, Jeremy and Liz, to answer some questions. There's some interesting questions have come, some with the same questions here. One is, can I ask you, and this is a repeated question, what about changes in requirements of alpha-calcidol during pregnancy? And I know, Jeremy, you do the pregnancy clinics at Norwich, but what should we do about any changes in the requirement for alpha-calcidol and calcium during pregnancy?
I think, broadly speaking, the changes don't seem to be dramatic, and I guess the underlying physiology is production of PTHRP during pregnancy. But of course, as we were saying during our discussion just there, it's so important to individualise your approach, and I certainly monitor my pregnant hypopara patients very, very closely and be ready to respond.
Thank you very much. Any other comment, Liz?
I completely agree with the close monitoring. That sometimes has to be fought for and is really important. Yes, and general decreasing of meds as you go, and then the need to increase again when you start breastfeeding.
Right, thank you very much. Now, another question's come in here, which is very pertinent. Hypocalcemia during COVID. Jeremy, I know you've been involved in looking after a lot of COVID patients. Can I say we've got a manuscript in preparation where we've been reviewing what happens in COVID. The hypocalcemia, remember, very often is related to a marked drop in albumin concentrations. So you need to be very careful about how you look at hypocalcemia during COVID. But Jeremy's actually dealt with a lot of COVID patients over the last few months and might want to comment further on this. But just beware, hypoalbuminemia is very common in patients with COVID, and that you need to look carefully at what's being measured in terms of the hypocalcemia that gets reported. But Jeremy, over to you on this one as well.
Well, keeping my comments brief, Bill, of course, Neil Gittos and colleagues have published some nice guidance around this question, so I would encourage people to refer to that. The other overriding principle has to be that avoidance is prevention is better than cure, and keeping our hypopara patients out of hospital, if at all possible, needs to be a primary goal here, I think.
Thank you, Liz. Any comments that you've had? I know patients have been contacting you about COVID and the problems of the COVID situation.
Yes, the hypocalcemia is a worry. I know a lot of people who are admitted have hypocalcemia, but what about when you have hypocalcemia already?
Well, obviously you need to treat the hypocalcemia appropriately under those circumstances, yes. I guess we're getting towards the end of this session. There are a number of people that have been raising the question of this idea of measuring the calcium before surgery. Beware, I published about 20 years ago the effects of hyperthyroidism on calcium, and just beware that thyrotoxicosis, you'll see in that paper, it was published in the 1990s when the new PTH assays became available, that hyperthyroidism actually causes hypercalcemia. So when you're making measurements prior to having surgery and cancer and hyperthyroidism, the calcium actually might not be that person's normal. So you might have to look look back before any disease process to find what a patient's normal calcium would be. And that comes back to Jeremy's point of finding the sweet spot for a patient post-operation. But I understand the guidelines saying measure before surgery. I think you need to measure before the patient becomes ill with either thyroid cancer or hyperthyroidism. But maybe Jeremy and Liz will also like to comment on that. Jeremy?
Well, of course, ideally, the patient's rendered euthyroid before surgery, Bill, in an ideal world. So hopefully the results might be somewhat representative. I don't know. Liz, I don't know if you have a take on this.
No. Really not very much information about preoperative. Just the importance of monitoring post-operatively, which needs to happen regularly.
Okay. Well, I see I've been monitoring the numbers. There's over 360 live viewers on this session, which is absolutely superb. There are a lot more questions. If anybody wants to leave an email address, I'm sure Jeremy, Liz and myself would be very happy to answer the questions that I've not been able to raise at this moment in time in this session. I'd like to thank you all for attending and say thank you very much, and I will bring this session to an end. Thank you, Jeremy. Thank you, Liz.
Thank you, Bill.